Florence Canoui-Poitrin and Dr. Mioin Ajej, who will co-present a talk about barriers and future direction for the inclusion of older adults with cancer in clinical trials. Professor Canoui-Poitrin is a medical doctor, professor of public health, and an epidemiologist who co-leads the CEPIA research team that works mainly on clinical epidemiology and aging. Dr. Ajej is an health sociologist, specializing in social inequalities. They recently published in the Journal of Geriatric Oncology a qualitative research conducted among oncologists and geriatricians in France on the topic of the inclusion of older patients in clinical trials. Florence Mewin, the floor is yours.
Thank you very much, Sophie. I'm going to share my screen.
Thank you, Sophie.
Is this okay for everyone?
Thank you, Martin and Sophie, for giving us the opportunity to present our research program regarding the inclusion of older patients with cancer in clinical trials. As Sophie said, we will focus this afternoon for us and morning for others, regarding the question of remaining barriers for improving and future direction for improving the inclusion of older patients in cancer clinical trials. Next, Mioin, please. We have no conflict of interest to disclose. We will follow the different steps. After a brief introduction, I will recall the historical perspective of inclusion of patients and persons in medical experimentation. After, I will present the different barriers for underrepresentation of older patients in cancer clinical trials, and Mioin will develop the patient perspective, and we will present the different ways to improve before a short conclusion. So as you know, the proportion of older patients including in cancer clinical trials is low and does not represent the reality of the proportion of patients in everyday clinical practice. We know that between 40 and 50% of new cancer cases are in older patients, older than 65 or 75, depending on the threshold. And the other thing is that these older patients, including in clinical trials, are usually fit and with less comorbidities than patients in real life settings. So at the beginning of the 20th century, it was the habit that deprived people, orphans or older people in home care, who are used to make medical experimentation. And after the Second World War and the Nazi experimentations, the different medical associations said that it is important to provide ethic and legal rules to protect vulnerable people in clinical trials And we had the Helsinki Declaration and several legal rules to protect vulnerable peoples like children or older people or mentally ill people. So after the Second World War, we had a trend to protect the minorities, the women, the children, and older people. And the underlying ideology was that, sorry, the biology universalism. We thought that an experiment in someone can be transposed to another people, child or older people. We know now that it's not true, but it was the safety and the protection rules who conduct to underrepresentation of women, minority, children, and older people. So this article show you the underrepresentation of older patients in cancer clinical trials compared to patients in United States data registries. And we can see here that the question of the minorities and the question of the gender balance between trial participants and proportions of incident cancer patients in the National Cancer Institute Cooperative Group clinical trials improved. That is, we can see that the proportion of non-white patient is quite the same in clinical trials and in cancer patient. It's the same for gender, even if it was driven by the high proportion of breast cancer. And we can see that, on the contrary, for age, the proportion of patients older than 75 years old is dramatically low in cancer trial comparing to real life of incident cancer patients. It was quite old data, but it's always the same now, as we can see in cancer trials from 2001 to 2011, that the proportion of patients aged 75 years and older is between 7 and 10% in cancer clinical trials in United States, whereas they represent more than 30% of new cancer cases. Another way to see the problem is the difference in median age. And a recent team work to quantify the difference in median age between participants of cancer clinical trials between, you can see, 1994 and 2015, and the difference was more than 6 years between trials and cancer registries, always in the United States. The question of underrepresentation of older patients in clinical trials is not specific for cancer clinical trials. And I take now the example of the COVID. As you know, this disease affected particularly the oldest regarding the severe forms and the death. And the mean age of participants of vaccine trials was 45. And only and less than 2% of patients was older than 75. So the question of the under-inclusion of older patients in clinical trials has to be understood regarding several levels. First, we have the level of availability of the trial in the center, and it's the first lock because a lot of centers, not in the big cities, not university centers, not tertiary centers, do not have trials open for recruitment. It is the first lock. The second, as you know, is the eligibility criteria. It's a well-known problem, and I will come back to this point after. The third step is the step of invitation. Is the trial discussed by investigators, physicians, or clinical staff to be offered to a patient? And the fourth step is the inclusion. When the trial is offered to the patient, does the patient accept to be included in the trial? It's a question of the patient and the question of the relatives and family caregiver. So at each step, there are different reasons of non-participation of older patients to clinical trial. And a very recent review makes the list of different studies regarding barriers first, and then intervention regarding older adult participation in cancer clinical trials. The first barrier are, as you know, eligibility criteria and trial availability, as we just see before. The second block of reason is the question of the provider, and the different problems are concerns for toxicity, concern for patient age, that they consider that he or she is too old to enter in a clinical trial, the time, the burden that is to include someone, and particularly someone aged and sometimes not with good autonomy or physical capacity, the preference for another treatment for his or her patient, the lack of personnel, the preference against research in general. And I conduct with my team a cohort study regarding patient with colorectal cancer in 7 centers in Paris area, and we showed that from almost 600 patients over 65, about 20% have no clinical trial recruiting, despite it was tertiary and university centers. For the tumor stage or site they have at the time the therapeutic decision was made. But the most, the highest rate of non-inclusion in a clinical trial was obviously the question of ineligibility, and it was mostly related to cancer-related factors. After it was the question of exams required before inclusion, for example, TEP scanner or MRI, which were not not available in the center, for example. The third reason was previous or concomitant treatment or excessively short time between treatment cessation, for example, last line of chemotherapy. Fourth, the question of performance status, the question of comorbidities, the question of inappropriate biological parameter, and endly the age limitation as eligibility criteria. The age limitation was a key problem before, I would say, 2005, something like that. But now it is quite rare that cancer clinical trials have a higher age threshold, and it's more indirect criteria which preclude inclusion of older patients. So we demonstrated that the problem of availability trial, the problem of eligibility was common for all age class, but more marked for patients older than 80s, which seems to be the threshold which we have to examine cautiously the inclusion of patients for entering in a clinical trial. Regarding the patient perspective, I will let Myo-In develop this question, and I will give her the word now.
Thank you, Florence. So what I'd like to do now is to switch gear and talk about patients' perspectives. So for over 30 years now, this concept of déprise in French has allowed French sociologists to account for and to analyze many facets of aging. And loosely translated, déprise means a hold, or prise, sorry, means a hold. So as in to have a hold on something. So déprise is the opposite, to let go of the hold. So this notion of déprise, it highlights the process of re-engagement of life that can take place with advancing age, during which certain activities or relationships are abandoned or replaced by others to cope with increasing difficulties. So these can be fatigue, health problems, increased awareness of one's finiteness, the disappearance of part of their contemporaries, an overprotective attitude of loved ones, or a less and less welcoming outside world. And all this exposes to manifestations of aging. So this term déprise was coined a few decades ago in opposition to the prevailing theory of disengagement of older adults with advancing age. And déprise was coined to highlight how engagement with everyday life and relationships can get rearranged with aging rather than, sorry, just fade away into a general disengagement due to changes and limitations that come with old age. So I'll be using this French word today as we can't seem to find a translation that really captures it. As for examples, déprise has been used by social scientists to study the experience of illness and its management, mainly through case studies of Alzheimer's. So that being said, little work has been done on cancer. And so in our research on cancer clinical trial, Benjamin Derbez, Florence and I were interested in the circumstances of older adults' participation. We wanted to further explore one of the findings that Florence presented, which is that while physicians may be reluctant to invite older patients, more often than not, older patients who are offered a participation in a clinical trial accept. So we decided to find out more about older subjects' perspectives. So between 2017 and 2019, we conducted a series of semi-structured interviews with patients who had been asked to participate in a clinical trial in 6 hospitals in the Greater Paris area. So of these 25 patients, 20 had agreed to the trial and 5 had refused. We were hoping to get more patients who had refused, but more often than not, patients tend to accept clinical trials. So for the analysis, we used a methodology inspired by grounded theory. And this inductive theorization led us to consider the experience of our respondents as one of biomedicalized déprise, in the sense of a testimony to the centrality of biomedical devices in the processes of life reorganization in old age. So today I'd like to discuss this notion of déprise for older adults involved in clinical trials. And so first, we'll show how the question of participating in research can be part of a process of déprise for older adults between letting go, keeping a hold on, and regaining control over everyday life. And second, this will lead us to analyze the social conditions that allow certain patients to seize the clinical trial as an opportunity for re-engagement. As an opportunity for re-engagement, so a form of reprise, where they built a new hold on everyday life and relationships, and namely trust in the biomedical institution and recourse to the resources of family and friends. So first, let's talk about participating in research. So by emphasizing the dynamics of reshaping, rearranging, and adjusting to living conditions, this notion of déprise, it allows us to better grasp the processes of disengagement in the experience of aging. So the analysis of the experiences of older patients who were asked to participate in the trial reveals that inclusion is permeated by a sort of ambivalence. A trial also implies giving up a certain daily activities, and refusing to participate can be understood both as forms of disengagement from treatment, but also as the sign of wanting to keep a hold on everyday life outside of medical care. So in terms of cancer, age, and treatment, let's look at a context of disengagement. So social scientists like to say that age is a social construction. So this means that age is not a given, it's not a fact. It's something of an understanding that we have collectively come to, or that we collectively understand what old age is or what old age should be. And this in turn affects what we do with and what we do to older people. So this process of social construction goes both ways. And in the case of older patients with cancer, they are less often offered chemotherapies than younger patients. For many observers, this is a sign that in routine practice, so I'm quoting the bottom quote here, in routine practice, older patients do not always receive optimal treatments or are undertreated compared to younger adults. And in its report, the French Cancer Observatory refers to this phenomenon as representations that often occur in society regarding older people with cancer. And these representations are an older person with cancer is first and foremost an older person, or in cancer management, the priority is not older people, or older people do not want to be treated. So among some oncologists, these representations would or could translate into a form of therapeutic abstentionism that is sometimes associated with the ethical desire to avoid unreasonable obstinacy. So according to this, it would be preferable to leave the elderly alone, and I'm using quotes here, rather than commit them to tiring and potentially iatrogenic treatments. So the question of appropriateness of treating the disease in older patients gives rise to a form of medical disengagement at 2 levels. First, at the level of research, and second, at the level of care. So in other words, there's less research and less medical care for older patients with cancer. And it can seem like a certain number of cancer specialists rely on a form of disengagement, understood here in terms of the negative aspect of the gradual disengagement of older patients from different spheres of life. So it can seem like a certain number of cancer specialists rely on a form of disengagement to lower their therapeutic and scientific ambitions. So the questions we ask here are, is this really the case? To what extent do excluding older patients from experimentation and medical abstention reflect a real disengagement of of older patients from biomedicine? Do medical scientific practices mirror the disengagement of the experience of cancer in old age, or is something more complex happening? So now let's see if is this a case of disengagement of older cancer patients. So we know that increased fatigue can happen with advancing age and cancer treatment. So it makes sense to wonder whether the advanced age of cancer patients and inclusion in a trial may increase this fatigue, given that it implies following a heavier protocol in terms of monitoring, visits, tests, etc. So during our interviews, we frequently heard people talk about a certain fatigue where the effects of age and the disease are combined. So one said, I'm tired, it's tiring. And this 80-year-old prostate cancer patient said, I can do some activities, but much less. I can't force myself to keep going anymore. I can't go on trips like I used to. And some patients also report slowing down with other practices related to various social roles that they used to have, such as volunteering, babysitting their grandchildren, or gardening. So at first glance, the experiences of older cancer patients seem shaped by a form of disengagement or déprise, in the limited sense here of dropping out of certain daily or social activities. So under these conditions, can we consider that older patients who refuse to participate in research are also dropping out or giving up? Here, we go against the idea that the decision to decline an invitation to participate in a trial is made by resigned older patients. The interviews we did showed that refusals can be interpreted as forms of resistance by older patients. So resisting the risk that biomedicine will encroach on their autonomy, for example. So like older patients in the studies by Hart in 2020 or Buse in 2008, older patients may not consent to a trial in order to maintain control over their daily lives, remain active and independent, remain able to assume their social roles. So this is suggested by Mr. C, who tells us about at the time he withdrew his consent from the trial in which he was included. So he told us that in his oncologist's office, I said yes because it seemed right. But at home, when I reread everything, I found it a bit complex, restrictive. So I told him that I preferred to withdraw. I was a bit uncomfortable saying this to the doctor because I had accepted initially, but I said, I don't want to continue. I have other pills. I have a cardiovascular treatment. I go back and forth to Paris, to the other hospitals in the suburb in Créteil. I want to live on the other side for a while. Sorry, I want to live on this side for a while without always being on medication and doing tests. So the constraints that are generated by the trial are clearly mentioned here as the reason for refusing to continue the trial. At his age, this man wants to live on the side. He wants the frequency of examination of tests and the distance between his home and the hospital. These no longer allow him to pursue his activities and hobbies as he wishes. So even when it's simply a matter of patiently undergoing examinations or treatment in hospital, this time taken by the trial can be perceived as conflicting with personal daily activities. So this is what Mrs. E said. And so she's an 81-year-old woman with breast cancer. And I'll skip ahead here. And she said to herself, you're not going to be able to go out at all. You're only going to be able to be in the hospital, doing your housework and sleeping. Yes, because you have to rest in between. So I said to myself, what are you going to do now? Haven't you done enough of that in your life? You deserve a little rest. So as you can see here, rest isn't synonymous with idleness or inaction. It's clearly associated with time to take care of oneself, one's own affairs quietly. And retirement allows for all the things that weren't possible when holding down a job or raising a family, or. So, oops. What did I do? Sorry. All right. Are we all seeing 1.2.3? I don't know what happened. Okay, taking this as a yes. I keep going. Thanks, Darianne, for answering. So I'll keep going with, so the third point about reconciling the clinical trial and social life. So attachment to daily life can be an important factor in the decision to participate or refuse a clinical trial. In contrast, some of the patients that we saw who were included in a trial said they were satisfied with their ability to maintain their social life during the trial. So like this 72-year-old former engineer who explained that he was always active, always in it, still in it, and even continued his classes with UNESCO despite the disease and despite the protocol. An 84-year-old patient told us, I mow my hedges, I cut my grass, I chop my wood, I do everything. And keeping a grip on her social life, continuing to assume her role as a grandmother and as a volunteer in a nursery school, is even described as a way to live well with the treatment for Mrs. F, who's 75 and included in a trial to treat her breast cancer. So I'll skip the quote here because I think you get the idea. But like this woman, some patients say that they were able to maintain an involvement in their daily activities during their participation in the trial. And in this case, there's a form of conciliation between the imperatives of biomedical experimentation and the framework of the various commitments that constitute ordinary everyday experience of older people. So now the question is, can we not go further and consider the clinical trial in itself as a mean of reorganizing the lives of certain older cancer patients? So let's now look at inclusion as an opportunity for engagement. As we've seen, participation in a trial involves a set of constraints, so more frequent hospital visits, more numerous clinical and biological tests, self-monitoring, etc. And this may imply a certain disengagement of older patients from practices of sociability, which are sometimes already weakened by age. But should these situations be analyzed only in terms of loss, of abandonment, or can they also be interpreted as more complex situations where patients choose to reorient their ties and their commitments in a strategy of maintaining what matters at their age? So we'll now see that for some older cancer patients, agreeing to participate in a trial is seen as an opportunity for engagement in an active fight against letting go. So for them, participating in a trial is a way of committing themselves to the patient collective and more broadly to others. So to become involved in the trial, in the biomedical experience, is to contribute to the progress of scientific medicine by establishing ties of trust with the research teams, for example. So for some patients, Inclusion in the trial represents a way of continuing the fight against the disease. So in a context of very poor health, where therapeutic options are reduced, it's a matter of accepting to take a certain risk in the hope of living. So a 72-year-old patient who's had prostate cancer for 2 years told us in the trial, I know I'm a guinea pig a little bit, I hope it'll be effective. If I do it, it's so it can be effective. And at my age, I'm not afraid of much anymore. I'm not risking much. And who knows, maybe they'll make progress with this trial. At least we're getting treated, because if it were a few years ago, I wouldn't even be here anymore. So here the term guinea pigs is used here clearly to show the awareness that some people have of lending their body to an enterprise whose benefits are uncertain and which involve risks. So for this patient, however, age and illness mean that he feels that he no longer risks much. And in these conditions, the hope of effectiveness plays a key role in explaining this commitment. So this observation shows that advanced age doesn't prevent people from taking advantage of the trial as an opportunity to treat themselves. It's a form of empowerment that the patient uses to continue to move forward as he's always done. Now, if therapeutic hope guides all the patients that we included and that we interviewed, some patients also engage in the trial out of altruism to contribute to medical research. So as one patient put it, I'm willing to be a part of this, of course, if it helps research. I'm of the opinion that I'm very well looked after at La Fondation Curie, and if I can help research in any way, I'm in, that's all. So in this sense, inclusion can be understood as an act by which some patients, despite their advanced age, try to maintain their attachment to the community, particularly to the moral community of patients. And helping other patients and advancing cancer medicine can therefore represent an opportunity for commitment. So a way of keeping a grip on the world around them, of remaining connected to the collective, and of retaining a social utility or usefulness that gives meaning to their approach. Now, in terms of activation of social bonds, among the social ties that are activated by participating in research, the older people that we met seem particularly attached to their trust in the doctor. Many patients explained that they had consented to their inclusion in the research because of the trust they had in their doctor. So one told us, if the doctor tells me something, I do it with my eyes closed. There's no question. She's my doctor. My doctor tells me something, I take note of it, and I follow it to the letter. So is it a question of blind trust in medical authority, which in older adults would be or could be a remnants of the old form of a paternalistic caregiver-patient relationship? Is this a case of patients agreeing to give up a little more of their autonomy, an autonomy that's already weakened by age? The analysis that we did, on the contrary, shows that it may also be an active form of risk delegation, so a mechanism for reducing uncertainty and complexity. So in other words, a deliberate choice on the part of the patient to keep a grip, even if it's indirectly, on his or her existence. And awareness of a gap between their knowledge and their doctors strengthens the bond between them from the patient's point of view. The long duration of medical care, which older patients know all too well, also plays a role in this respect. The personal trust expressed by older patients towards their doctors, who have sometimes been with them for years, allows them to keep control of their care trajectory by delegating the decisions to include them. In this sense, participation in the trial constitutes a form of commitment to the world, reprise, which is constructed in the relationship with the medical institution. But we'll see now that this happens also with the family institution through the relationships of care and support. So let's now talk about family support. So relatives and loved ones are also a crucial resource for the older patient in a trial. Relatives are called upon to support the patient to enable him or her to follow the protocol. So entering a trial for an older patient is therefore an opportunity to remobilize their loved ones around them. So when we asked about his wife and children, one patient said, "Oh, they don't show it. They're amazing, of course. They don't show it. But they always take care of me. They've always cared, you know. We're still a tight family. My wife won't even let me come here by myself. So I'd say sometimes I can come by myself. No, I'm coming with you, because she doesn't think I ask questions and stuff." I said, "No, I mean, there's no discussion. She absolutely wants to be there." So the work of these relatives involves accompanying, supporting, being present to ensure that the work of articulation, of coordination of medical action, which usually falls onto the patient, if we think back to Strauss's work in 85, in most of our interviews, the presence of the family was mentioned and emphasized by the patients. "We are united family," says another patient about the support of his relatives. Participating in a trial, it therefore requires work from the spouse, the children, and the relatives. And it's another way of reorganizing one's social relationships, a way of engaging in daily life in a different way. This goes against the assumption that aging is accompanied by disengagement. And here, participation in the trial allows for the remobilization of family ties. So as a form of pre-conclusion before the conclusion, we can take away from this that, contrary to common representations concerning the tendency of older cancer patients to want to disengage from treatment, to wish that their professionals would just leave them alone, quote unquote, our research shows that some of them can seize the opportunity of inclusion in a trial as an opportunity for engagement, through which biomedicine allows them to maintain or even strengthen their social attachments. We think this re-engagement of living conditions can be read as a form of biomedical déprise, as many researchers have pointed out. This déprise shouldn't lead to an understanding of the concept that emphasizes decline and disengagement from life with age. We agree with them, and we think it's useful to use this notion to better understand what's at stake in the participation of older cancer patients in trials. And we've shown that if the trial is often accompanied by abandoning certain activities or social relationships, so déprise, it can also be seized by patients as a way of rearranging their modes of interaction with the world, so reprise. The trial can be a step towards a process of rearrangement, which leads to a slowing down of practices related to different social roles, a letting go or déprise in its narrow definition. This kind of approach allows to bring a useful complement to the reflections or the debate around the social construction of the category of older person in medicine. And biomedical age, which is correlated with comorbidities. It's frequently used to minor the importance of chronological age of individuals. So what the example of participation of older adults in clinical trials shows here is that work on the notion of déprise, prise, or reprise can also make it possible to emphasize the differences that exist between the civil age and the social age of patients. This is what is at stake in the interdisciplinary dialogue around the notion of disengagement and our understanding of what old age is in the health and social field. So now I'll let Florence take us through the ways we could improve participation of older patients in clinical trials.
Thank you, Myrine. I will go to the conclusion of this talk, but before we wanted to give some some direction from the literature to improve the participation of older patients in cancer clinical trial. We showed that the reasons of under-inclusion are complex, are multifaceted, and play at different levels. And it's easy to perceive that the same will apply for ways to improve. And we have an accumulated evidence for barriers, and even if there is some space to investigate more precisely the reasons for underrepresentation of older adults, there is a problem with the very few number of papers regarding interventions to improve participation. There is quite a paradox between the accumulated evidence for articles regarding barriers to include older patients in trials and the very few number of articles regarding interventions. So I will present the only one regarding educational intervention for physicians and staff, which was an intervention for educate physicians and staff for the benefit and to be aware of the problem for including older patients in clinical trials. So several speakers and leaders in the field built an educational symposium and educational materials and monthly reminder directed to trial providers in different centers, and explain the barriers, the question of the toxicities of cancer chemotherapy and the determinants of geriatric assessment and its relation to prognosis and toxicities and the effect of comorbidities. And so different educational materials was provided to physician and clinical staff. However, the result of this randomized trial was negative, but the point is it is the unique trial in this field. So a very recent article presents a recommendation to expand the inclusion of older adults in cancer clinical trials. I won't make the list, but as you can say, there are some recommendations which can work or not. But the problem is that there is no intervention that attempt to test these different recommendations in different settings. Another example of what we have to do in 2012, there was a publication of the different steps to go toward the Geriatric Research Equity Act to have more mandated registration trials with appropriately subgroup of patients of all age, to have post-approval trials after drug approval and inclusion of patients older than 65 and appropriate subgroup and sub-analysis of patients of this age, and pharmaceutical intensive to open additional efficacy and toxicity data in older adults to inform the package insert in drugs. the FDA published several guidelines for 30 years, and the last was in 2020. And so we with these different guidelines and other institutions through the world had made the same. But so the barriers are known, the guidelines are here. However, as we said, and in introduction, the proportion of older patients stays the same. European projects present specific ways to improve and propose to recognize that inclusion of older patients in a trial is a specific task for physicians, for nurses, for clinician staff, that it needs extra time and needs specific skills. So they propose to recognize this effort and to give financial fees for physicians and nurses and clinician staff to recruit older people. Another article from Friedman and collaborators in The Oncologist ask more than 1,000 physicians and staff and nurses and statisticians and sponsors, and ask them what, to their point of view, what they need to improve the participation of older patients to clinical trial. And the 4 points the most answered are to create more dedicated trial for older patients, to minimize exclusion criteria focused on comorbidities, and to consider distinct strategy to increase enrollment for those aged 65 and 70 and older, and require that most alliance trial, it was the alliance trial in United States, have a specific expansion cohort of older patients with embedded statistics for outcomes like toxicity and quality of life for older patients. So I would say as a conclusion that despite more than 30 years of effort, institutional, political, scientific effort, we have no trend for improving participation of older patients in cancer clinical trials. And we know that the proportion of older patients in new cases of cancer will increase. The barriers are extensively studied worldwide. There is an international consensus for ways to improve. So now it is time to move from cognitive research to interventions. I thank you for your attention.
Thank you for that excellent presentation. I'm not sure if we still have Soda on the call. Does anyone have questions for our presenters? And in the meantime, as other people are thinking, I really enjoyed your presentation. I was wondering, in terms of how you, in the literature, there's nothing about incentives for patients. There's financial incentives for physicians and things like that. But what do we know about providing transportation for patients, or making it more feasible to participate, or giving a token of appreciation for patients and things like that? Because all the focus was on physicians and how to reduce their barriers. But what can we do for patients to make it more easy to participate? What did you come across?
Yes, thank you, Martin, for your question. Yes, it depends from the care system. It's in France, for example, the transportation are fully reimbursed for a clinical trial or for the disease. But I know it's not the case in every state. I am not aware of financial intensive directly for the patient, but what I saw in the literature is that we could try telehealth and avoid visit from visit to the center. What authors suggest is to avoid clinical trial visit for older patients and to I don't know if it exists in an intervention, but what authors suggest is to consider telehealth or at-home visit by a nurse or a clinical research assistant, which can avoid visit for the clinical trial, especially for older patients. Sorry.
Thank you. Other questions? I can't see the rest of the participants on my screen because I'm on my phone. So,
sorry, it's Schroeder. First of all, thank you both speakers for your excellent presentation. I don't really have a question, but just more of a comment, and in particular, because a lot of us, we know about the underrepresentation of older adults in clinical trials, and oftentimes it's maybe tied to misunderstanding of their actual functional health and ability to withstand the trial, but also maybe related to ageism as well. And we all are to some extent quite familiar with that narrative, but it's really eye-opening to see the patient's perspective on the other side and get to see how older adults feel. We know that sometimes they do drop out from clinical trials because of disease progression or other medical reasons, or they're no longer interested. But this is really interesting, in particular when I heard about in today's presentation, the constraints that are imposed by the trial, all these restrictions and all these hoops that they have to go through, and distance from the cancer center and all these things. And when in reality, sometimes maybe they just don't want to be bothered with all these constraints. They just want to enjoy, like you said, their daily activities and all those things. So it really, I think it changes the narrative a little bit, and to be able to see how older adults perceive what it's like being in a clinical trial. And I think that there's actually this tension between how to maximize our inclusion of patients in trials, and at the same time really taking care of all these barriers that they may be dealing with, so that we can help them stay in trial if they are interested. So I think, yeah, that may be something interested to consider moving forward. But thank you. This is really eye-opening for me.
Thank you.
Thank you. I don't know if
I saw a question from Faye on the chat. She might not be able to speak up, where she asked how DPs can be used to inform interventions.
Thank you, Faye, for your question. Usually the way we work is to, the way I work is to do the research and then present it in ways that healthcare professionals can understand it and then apply it to their own practice the way that they see fit, depending on their specialty, on their types of practice. I think it's difficult for me to make recommendations on interventions in general, but I think that as Schroeder just put it, understanding the patient's perspective and having the other side of the story can help in understanding why patients behave the way they do, and why they can adhere or not, be compliant or not. And so qualitative research in looking into patient experiences is really important to to interventions in general. And I think more and more, to come back to the topic of clinical trials, more and more clinical trials are asked to have a qualitative study within them. So if this is the case for this study, it's also the case for a number of other studies that we're doing at CEPIA with Florence and other researchers. To give, can I give an example? Is that okay? Yeah, we're actually working on now a trial that is looking to see whether intensive intervention by a geriatrician improves the outcome of surgery for older patients with digestive cancer. And so within this trial, I'm conducting a smaller qualitative study on on the circumstances of participation by patients and also by professionals. And so when we present studies that combine qualitative and quantitative, it gives us a fuller picture of what's going on. And I think the more we understand, the better we can choose to tweak our own interventions, depending on our profession, our specialty.
Thank you. I see we are 5 minutes past time, so I would really like to thank both speakers for their excellent presentations. It gave me a lot of ideas of what we can do differently. And so I will stop the recording, and then once the recording becomes available, I'll let you both know. And then Florence will upload it on the SIOG Nursing Allied Health website for everyone else to see. And then I would like to thank all the participants for joining us today. And then have a lovely evening and have a lovely afternoon for everyone who is on this side of the pond. And then, we look forward to hearing more about your work, because I agree with Schroeder. It's great to see the patient perspective and all these things, and what we can think about how we can improve that.
Thank you, Martine.
Thank you, Martine, very much. Thank you. And thank you all for everyone.
Hello, excuse me, I have a question. Is it possible